All right, we'll move on to the next speaker. Dr. Bradley Gardiner, welcome. Bradley is an ID physician and researcher at Austin Health, Monash University in Melbourne. Welcome to a clearless blue sky of a Brisbane autumn. I've checked, there's not a single cloud in the sky. Bradley's interest is in prevention, early detection and management of infections in immunosuppressed patients, particularly transplant. Recently completed a PhD looking at individualizing CMV prevention and treatment in transplant recipients. And that is also your clinical interest. So we're very much looking forward to your topic, cytomegalovirus, immune assays in heart and lung transplantation.
Great, thank you very much. And thanks for the invitation to speak today. So I guess the PhD may not be that recent anymore. I should probably update that. But I am going to talk about some of the work from my PhD today, immune monitoring in the management of CMV infection in transplant recipients. So CMV remains a huge problem, contributed to morbidity, graft loss, mortality in transplant recipients. And, basically the problem is you've got lifelong latency, ongoing risk of reactivation. And although we have really highly effective antiviral agents, they only really work by blocking DNA synthesis, so they only work while you're taking them, right? So there's always this risk of recurrence. We know a lot about preventative and management strategies. There's really clear guidelines available, and this has definitely reduced the incidence and severity. However, while there's less of it around, it still occurs, and our current approaches mean that everyone is treated the same, even though many will not actually reactivate. Up to a third of patients can get problems with neutropenia from valganciclovir, and there's a whole bunch that will develop late onset, and then a whole bunch of patients will go on to develop late onset disease despite prophylaxis anyway. And then there's this alternative option of preemptive monitoring, which is really resource intensive. And I don't think anyone really does that in a true preemptive way in Australia, maybe some liver transplant centers, because you kind of need weekly testing and someone to actually check the results and then action them within a reasonable time frame. And what threshold do you use for treating, and progression can occur rapidly. So that's not perfect either. So it'd be really helpful to have a way to just accurately predict who's going to develop CMV problems. One of the problems is that's not straightforward. And one of the reasons it's not straightforward is because the immune control of CMV is so multifaceted and complicated. There's been a lot of focus on T cells historically, but NK cells are increasingly recognized to be an important part of that. And then there's humoral immunity as well. And so any single test that's available actually only measures like one little piece of this pie, and that's one of the complexities. So immune monitoring is appealing in a lot of ways. The idea is you measure the immune response to either a specific pathogen or in general, and there's two kind of goals, both to predict infection, but also for some of the assays to measure the net state of immunosuppression, which I'm not going to really talk too much about today. And the ideal assay, like any test, is cheap, simple, accurate, and clear and easy to interpret. But unfortunately, these are the tests we have, which don't tick all those boxes. We've got, 4 kind of technologies, one of which is really a research use only. And then there's 3 kind of commercial platforms, basically, the quantiferon CMV, the ELISpot assays, of which there are 2 varieties, and then more recently in the US, this has become commercially available, but there's really limited data available on this, and they've all got their own pros and cons. So the quantiferon CMV measures interferon gamma release. So basically, you collect blood, you pop it in the tubes, 3 tubes, CMV tube, mitogen tube, nil control, and then you stimulate it with CMV antigens, and you measure interferon gamma. The ELISpot is a little bit more complicated, but basically you extract blood from the patient, you purify out PBMCs, and then you stimulate them, and then you pop them on this plate, and then you get this like readout, which every T cell, every spot represents a T cell, which is reactive to the antigen, the CMV antigen, right? You've also got these global immune monitoring assays, and some of these are very old, like immunoglobulin levels. Technically, that's kind of an immune monitoring assay, but not in the kind of sense, I guess, that we think about now. We've got the absolute lymphocyte count, which is one of my favorite tests, and I'm going to talk about some of the studies we've done with that today. Lymphocyte subsets, and then a few of these other non-specific immune biomarkers, which are very interesting, but are a topic for another day. So when I think about CMV, I think about the post-transplant patient journey, basically. And that, I think, is a really important way of figuring out how you're going to interpret these tests, right? So patient gets a transplant, they pretty much all get a period of primary prophylaxis, then some will develop post-transplant, post-prophylaxis CMV infection. That will be treated. Then some patients will get some secondary prophylaxis after that, and then some patients will develop recurrence. And basically, you can apply these assays, the CMV immune monitoring assays, at any of these time points post-transplant, before transplant, just before, during primary prophylaxis, at the end of primary prophylaxis, at the onset of viremia, at the end of treatment, and at each time point, they mean something different, right? So, so what they're trying to predict varies, and the clinical decision they're trying to inform is different. So, you can use it before transplant to decide, are you going to use prophylaxis or not? You can use it early post-transplant during prophylaxis to figure out how long you need to continue your prophylaxis for, and what's the likelihood of CMV reactivation occurring after you stop that prophylaxis. You can use it at the onset of viremia to figure out what's the likelihood of spontaneous resolution versus progression of infection, and inform a do you treat or not treat decision. And then at the end of prophylaxis, you're trying to predict recurrence. And one of the problems is that there are heaps of studies now available on this, and they're all slightly different, and they all approach the problem in a different way, using different assays in different patient populations, often combining together recipient positive and D+R- patients with different induction regimens, some getting thymo, some not, some getting prophylaxis, some not. And even there's problems with outcome definitions. What outcome do you use? Low-level CMV viremia? Do you use CMV disease? So there's a real heterogeneity in the literature, and it's hard to kind of make sense of it. So what I've tried to do is break it up by these various time points and sort of go through a few of the key studies for each one. So the lymphocyte count story really begins back in 2009 when Maria Fernandez-Ruiz, who's a really prolific researcher in this area in Spain, looked at 63 liver transplant recipients and found that if your pre-transplant lymphocyte count was less than 1, this was associated with post-transplant infection, half of which was CMV related. And that was really highly predictive. And then I did a fellowship at Tufts Medical Center in Boston. And just before I got there, one of the other fellows had kind of basically repeated that study, but in a larger cohort and a bit more sophisticated analysis, and found again that pre-transplant lymphopenia was associated with CMV and other infections post-transplant. And that kind of inspired my study, which I'll come back to a bit later. People have also looked at using the CMV quantiferon and the other assays pre-transplant. And basically, if you just look, these guys looked at 55 patients who were all recipient positive and split them up by quantiferon positive or negative. And basically, if you were quantiferon negative, recipient positive, your risk of CMV was much, much higher than those who had pre-transplant CMV immunity. But really, most of the action has been during or at the end of primary prophylaxis, and there's a few studies that I'm going to tell you about. So this is the first one from Oriol Manuel's group. He's from Switzerland. He's another key researcher in this area. So he looked at 127 donor-positive recipient-negative kidney transplant recipients and looked at their quantiferon results at the end of prophylaxis and a month or two later. And basically, the majority of them were actually negative. And the frequency of CMV infection was much, much higher in patients who were indeterminate as opposed to positive or negative, which is kind of interesting. So this really is reflective of the mitogen tube within the quantiferon CMV assay, which is more of a global immune biomarker rather than actually measuring a CMV-specific immune response. That's kind of interesting. And then that led to our study. It's chronologically out of order with the way I've done this work, but it makes sense clinically to do it this way. So when I got back to the Alfred, basically they had been looking at the quantiferon CMV to guide primary prophylaxis duration in the lung transplant recipients, and they'd done a trial basically, and they introduced it into routine clinical practice. And essentially what they were doing was testing people at 5 months post-transplant. If their quantiferon CV was negative, then they would extend the prophylaxis to 11 months. And then so they'd randomize people to either standard of care, which at that time was just 5 months fixed duration, versus this quantiferon guided approach, and then looked at CMV after that. And so the original trial included 120 transplant recipients, a quarter of whom were D+R-, and they demonstrated less CMV infection in the quantiferon directed arm, and then they rolled it out basically. So then I arrived and I was sort of said, oh, well, we've got all these patients now that have had quantiferon testing. Why don't you just look at them and see what you can come up with, and you know, make some more sense of it basically. So really, I then wanted to understand who it was who was developing a quantiferon specific immune response, and like compare this approach to actually just our standard serostatus based risk stratification. So I did another sort of retrospective analysis of all the patients we had at that time and looked at CMV infection within 2 years. And we were able to pull together 263 patients, around a quarter of whom were D+R-. And basically, you know, 3/4 of them were on this quantiferon guided pathway, which meant, you know, so that half of them were quantiferon positive and stopped prophylaxis at 5 months, and then the others were quantiferon negative and had extended prophylaxis. And then there are a hodgepodge of other patients who just were the opposite for whatever reason. And so basically we had 4 groups in the end. So this is just a simple representation of the people who were on that quantiferon guided pathway. And you can see, yes, they are getting less CMV compared to those who weren't, right? And that's in both the blood and the BAL, which is one of the complications in lung transplant recipients. You've got multiple sites of infection. So I broke it down then by both the quantiferon result at that 5-month time point and the duration of prophylaxis. And you can clearly see that the highest risk group are the patients who are getting shorter durations of prophylaxis, and extended prophylaxis result in less CMV, but there are differences here with positives and negatives. So then I looked at, okay, well, who is it who's actually positive at 5 months, right? And basically we did a logistic regression. We used the positive test as an outcome, and we found that actually the only thing that predicted whether or not you had a positive quantiferon at 5 months was your serostatus, right? And so the donor positive recipient negative patients hardly ever had a positive quantiferon whilst receiving antiviral prophylaxis at 5 months. And sorry, I'm just going to jump through a few of these. So really, serostatus is one of the most important factors associated with CMV infection, right? So, and you can see here the donor positive recipient negatives, pretty much all of them got CMV anyway, regardless of their, hardly anyone actually was quantiferon positive, and even the ones who were quantiferon positive also got CMV, basically, in both the blood and mainly in the blood, actually. And then out of the recipient negatives, you know, you can see that the quantiferon results, so if you stop prophylaxis at 5 months, it doesn't matter whether your quantiferon is positive or negative, you're still going to get, half of them are still going to get CMV infection anyway. We plugged it into some multivariate models to try and see, and basically, if you just look at the quantiferon result and the serostatus by themselves, both, so a negative quantiferon is, unadjusted associated with CMV infection. But if you adjust for serostatus, that just totally disappears. So basically, it's not really telling you that much above serostatus, was our kind of conclusion. And so the incremental predictive value was limited, and really it's all about the prophylaxis. And the longer you go with prophylaxis, the less CMV you see. And so to sort of understand this, basically you've got to work backwards. We've got all these lung transplant patients, who are getting CMV infection, and we thought it was this quantiferon guided approach that was really what was the benefit. But actually, that was really just reflective of what the quantiferon CMV results were and what duration of prophylaxis the patient got. And that really was determined by like serostatus. So actually, you don't need the quantiferon test. You just know upfront at the time of transplant that if they're D+R- and they're getting a lung transplant, they're pretty much all going to get CMV infection. And so So we stopped doing this testing actually at that point, and we just then committed the D+R minuses to indefinite prophylaxis if they can tolerate it. And, you know, that has had a benefit actually. And with the recipient positives, we extended it to 11 months, and then we stop and watch. And most of them who get a bit of CMV pop up. It's not such a big deal. It gets treated, and, you know, and that's that. So that's what we're currently doing. Anyway, so our enthusiasm for those tests significantly waned, but internationally there is still like ongoing large-scale clinical trials. So, for example, this one, which in Canada, which looked at 370 kidneys, which combines serostatuses again, and they didn't actually control for that in their analysis. So they looked at that they concluded that the test is predictive and there's less CMV if it's positive, but they might have made the same mistake that we did with the original trial, I suspect. And then more recently, and this is where it might become more useful, is that people have started to hone in on like specific subgroups. So Mario again looked at 120 recipient positive kidney recipients who all got thymo-induction. Pretty niche group. And then he looked at their quantiferon results, and he actually found no real differences in CMV infection, if positive or negative, and concluded that it was not a very accurate test for predicting CMV in this subgroup, right? But then these guys looked at 150, and they actually, this was an interventional study where basically they did monthly quantiferons in kidney transplants, and then if it was positive, they stopped their Valgan. And one of their key outcome measure was duration of prophylaxis. And they did find a little bit shorter, you know, use of Valgan, like a month less or whatever of Valgan in the patients who were getting this intervention. And that was sort of replicated by Oriol Manuel again, 185 kidney liver recipients, mostly kidney, you know, half R+. Basically they did monthly LE spots and stopped the Valgan if it was positive. And they saved about a month of prophylaxis. And I was like, geez, a month of prophylaxis, all that effort for a month of prophylaxis, like, why not just give them a month of prophylaxis, right? Like, anyway, so that's kind of getting figured out at the moment. And interestingly, if you break down the responses, so this is the two different antigens in the LE spot assay, and these are the recipient negatives here. You can see, similar to us, like hardly anyone who's recipient negative actually becomes LE spot positive while they're on prophylaxis. And it's really like after that where they become positive. But maybe it's more helpful in the recipient positive group where you've got a more even split. But yeah, what was their hazard ratio? Like 1.6 or something. Yeah. All right. So onset of viremia. So that's really the meat of the current studies, right? So at the onset of viremia, these guys looked at 37 recipients, mostly recipient positive. Their threshold for therapy was very high. But basically, if you were quantiferon positive at the onset of your viremia, you were more likely to spontaneously clear your CMV infection without needing antivirals. But like 15,000, I don't know how that we treat anyone basically above 1,000, you know, and often people below that as well. And so you got to wonder about what harm that's going to do to the patient if you let that run. And then treatment completion. So I'm going to tell you briefly. I know a number of you have heard about my lymphocyte count study before, but I've just kind of got a couple of slides on this. Basically, while I was in the US, you know, inspired by the lymphocyte count story, we looked at 170 heart, liver, and kidney recipients and used recurrence as an outcome. And we found that the patients who went on to develop recurrence had lower absolute lymphocyte counts at the time of treatment completion. And that if you were less than 0.6, you were 11 times more likely to get recurrent CMV infection. And that was independent of receiving anti-lymphocyte therapy, of recipient serostatus, and of whether or not you had really high level viremia. And, you know, the lymphocyte count is a really simple, easy, inexpensive test. And like, that's a pretty useful clinical tool, actually. They've also, these guys, Dupali did this sort of interventional study, which is kind of interesting, a little proof of concept study. Like, again, at the end of treatment, they looked at quantiferon positives versus negatives. The negatives, they gave 2 months of prophylaxis to, and despite that, 70% of them recurred versus positives, which only 1 out of 14 relapsed, which is kind of interesting. So, you need an immune response to CMV to protect you against recurrent CMV. That's the takeaway from that one, I think. So So these are the conclusions of sort of this, array of literature, like that in my brain at least. So the immunoassays have really improved our understanding of post-transplant CMV immunity and infection risk, but their interpretation is very context dependent. It depends on when you're using the test, and that will predict different outcomes and inform different decisions. It depends on the serostatus of the patient relative to where they're at relative to prophylaxis. Are they on or off prophylaxis? What organ they have received, with kidneys probably being very different to the lungs, and everyone else in the middle. And then have they got thymoglobulin or not? And all the heterogeneity in the earlier studies really makes it hard to tease out what's going on. And look, they do have the potential, some of these tests, to inform like antiviral prophylaxis duration, frequency of monitoring, and immunosuppression management perhaps. But, how we're going to implement these is really difficult, and so moving from this sort of standard cookie cutter approach to like this more nuanced kind of strategy of like using these tests to figure out who's at risk and who's not at risk, and who's going to benefit from intervention A or B is like not sorted out yet. But more work to do. So which test is like the test? Is it just one test, or is it multiple tests combined together? How do we access them? I mean, some of these aren't even licensed in various jurisdictions. When do you use them? How do you apply results to the patient in front of you easily, quickly? And so, we probably need larger, carefully designed studies to sort of further evaluate this. And maybe the way to do it is to hone in on like one specific population or question at a time. So yeah, these are acknowledgements for our work. And thanks very much again. Yeah.
So at times that was a bit of a nail biter. Some of us were getting excited about introducing the quantiferon CMV into yet another algorithm, but simple and elegant ALC is
maybe that's the way to go.
Perhaps reflective of the mitogen response.
Yeah.
Maybe. Any questions?
Thanks, Brad. Amazing talk as always. I was just thinking during your presentation, do you think this might change in the setting of letermovir prophylaxis, where you're more likely to expect these blips in viral load that may stimulate an immunological response, that this whole landscape may slightly change in the Valgan cycle or the post-Valgan-Cyclovir era?
Yeah, it will be different again, and that'll be another factor. And I know that they have looked at quantiferons in one of the letermovir studies. I don't think it's published yet. And I guess the snippet that I heard was that there actually wasn't much of a difference, but we need to see. And there is a theory there that you've got a little bit of CMV, it's going to stimulate an immune response, and maybe that will be beneficial. And yeah, because you get a little low-level replication on letermovir, basically.
Thank you. Excellent talk. I had a quick question about the lymphocyte counts. I know that immunosuppression in its own isn't directly correlated with, I guess, CMV reactivation compared to lymphocyte subsets. But what do you think about manipulating lymphocyte subsets with adjustment of like immunosuppression?
So if you see someone who's lymphopenic, making an adjustment to try and back off.
Yeah. So dropping mycophenolate preemptively to bolster the lymphocyte counts.
Yeah, it's I don't think there's any studies that have looked at that. It's an interesting idea. And that would be one way to sort of move towards a personalized medicine approach in immunosuppression management, right? Like to sort of use these tests to kind of say, okay, well, 500 BD of mycophenolate means this for you, but that for you, for patient Y. But yeah, that's an interesting idea.
And if I may have the privilege of asking that last question, I do think, the rates of neutropenia were quite different, and we grapple with it on a day-to-day basis. So I wonder whether, in fact, the test could be beneficial to make a decision at the bedside. Do you have a comment on that?
Yeah. So if someone's tolerating their Valgan fine, it's easy to continue it for whatever months or years that you want to. But if someone is having problems, and obviously they're the patients that really are the issue, and they are often high risk for CMV actually, because they are not only neutropenic, but also lymphopenic and, highly immunosuppressed often and getting problems, and they're the hard ones. And the problem is, right, like if their quantiferon is positive, it doesn't necessarily mean that they will not get CMV infection, right? And so you still have to look for it anyway. And that's one of the challenges, you know. How does that, maybe they'll be a bit protected, you know, but yeah, that's one of the reasons why it's not just a clear cut, this person will be fine, you know.
Okay, thank you. Appreciate it.